Specific fractures and joint injuries in adults. Specific features of fractures in adults. 1. Fracture less common but more serious. 2. Weaker and less active periosteum. 3. Less rapid fracture healing. 4. Fewer problems of diagnosis. 5. No spontaneous correction of residual fracture deformities. 6. Differences in complications. 7. Different emphasis on methods of treatment. 8. Torn ligament and dislocations are more common. 9. Better tolerance of major blood loss. The hand. General features, common and serious. Hand function is related to its anatomical form, especially fingers and thumbs. Close relationship in gliding tendon of bones, only small margin of thoracic imperfection. Distal phalanx fractures. Crush injuries of the distal phalanx are common, particularly in industry, caused by the fingertip being caught in the closing door. Usually comminuted, the soft tissues are infiltrated by an enlarging hematoma. Treatment: simple aluminum splint serves to protect the crushed fingertip from further injury during the healing phase. Middle and proximal phalanx fractures, the result of either crushing or hyperextension injuries. Undisplaced, usually stable, treated by strapping the injured finger to an adjacent. Displaced, tend to be unstable, treated by Orif K wire. Usually comminuted, the soft tissues are infiltrated by an enlarging hematoma. Figure 17.2. Adhesive strapping for an undisplaced fracture of the proximal phalanx of the index finger. The adjacent uninjured fingers serve as a splint, and the two fingers are free to move together as a unit, the body system. Boxer's fracture, neck of the fifth metacarpal fracture. Street fighter's fracture results from an unskillful blow with the clenched fist. Characteristic depression of the metacarpal head and posterior angulation at the fracture site. Treatment: reduction and immobilization with the finger in position in a padded plaster no longer than 2 weeks. Figure 17.7. Angulated fracture of the neck of the right fifth metacarpal, street fighter's fracture in a man who had become engaged in a brawl with more vigor than skill. Coles fracture, the most common fracture in adults older than age 50 years. The patient either slips or trips and in an attempt to break her fall, lands on her open arm with the forearm pronated, breaking her wrist. Clinical features of Coles fracture: dinner fork deformity, swelling, obvious joint proximal to the wrist, hand is radially deviated. Figure 17.16. Typical clinical deformity: dinner fork deformity of a displaced fracture of the distal end of the radius, Coles fracture in an elderly woman. Note the joint just proximal to the wrist. Radiographic features: in the stable type, there is one main transverse fracture line with little cortical comminution. In the unstable type, there is gross comminution, particularly of the dorsal cortex, and also significant crushing of the cancellous bone. Figure 17.17. Left, lateral radiograph of a stable type of Coles fracture, there is little comminution. Figure 17.18. Right, lateral radiograph of an unstable type of Coles fracture, there is gross comminution, particularly on the dorsal cortex, and also significant crushing of the cancellous bone. Treatment of Coles fracture: undisplaced, immobilization, and below elbow casting for 4 weeks. Displaced, Cross reduction and cast spleen immobilization for 6 weeks with the position of ventral, ulnar deviated and supinated. CRPP, close reduction percutaneous pining, indication stable volar cortex and extraarticular. ORIF, indication angulation more than 5 degree, shortening more than 5 mm and displacement interarticular. External fixation, indication severely comminuted and open fracture. Anterior dislocation of the shoulder, predominantly of young adults, particularly athletes, caused by forced external rotation and extension of the shoulder. The patient is immediately aware that something has given way or gone out of place and is unable to use the arm. Clinical features and treatments. Radiographic finding. The humeral head has lost contact with the glenoid cavity and is lying in the subcoracoid position. Treatment. Patient merely lies face down on an operating room table with the injured arm to which a weight is attached hanging over the padded table edge. If this method has not resulted in a reduction of the dislocation within 10 minutes, a general anesthetic may be required. While an assistant applies constant traction to the upper limb with the shoulder in adduction, the surgeon can apply lateral and backward pressure on the dislocated humeral head with his or her hand, thereby reducing it. Figure 17.43 Radiographic appearance of an acute anterior dislocation of the right shoulder. Note that the humeral head is no longer articulating with the glenoid cavity and is lying in the subcoracoid position. Compression fracture of a cervical vertebral body, caused by flexion injury of the cervical spine without disruption of the posterior spinal ligaments, most significant anteriorly. Treatment. Reduction of a wedge compression fracture of the cervical spine is neither necessary nor advisable. Support of the cervical spine in a plastic collar provides comfort for the patient during the 3 weeks required for bony healing. Figure 17.51 Adjustable plastic collar for the support of the stable injuries of the cervical spine. Fractures of the metatarsals. The metatarsals are most commonly fractured by either a heavy object dropping on the forefoot or a run-over injury with a metal wheel. Frequently more than one metatarsal is fractured, in which case the most significant aspect of the injury are not the fracture, but the internal hemorrhage and impairment of the circulation to the forefoot. Pressure dressing and elastic bandage must be avoided. A well-padded plaster cast is preferable. Kirschner wire fixation is required to stabilize multiple fracture occasionally. Figure 17.66 Displaced fracture at the base of the left second, third, and fourth metatarsals, and undisplaced fracture of the base of the first metatarsal in a workman whose foot has been run over by one metal wheel of a heavy trolley. The foot was grossly swollen and the circulation to the toes was temporarily impaired. Fractures and fractures dislocations of the ankle. The distal ends of the tibia and fibula are fractured more often than any other bone with the exception of the distal end of the radius, particularly painful and unable to bear weight on the injured ankle, swelling and deformity. Figure 17.72 Clinical deformity of a fracture dislocation of the ankle. This patient has sustained a second-degree injury with fractures of both the medial and lateral malleoli. Note that the foot is displaced laterally and rotated externally in relation to the leg. Fractures of the shaft of the tibia and fibula, particularly vulnerable to direct injury in automobile and motorcycle accidents, largely angulatory, and the resultant fractures tend to be of the transverse or short oblique type. Rotational injuries of the tibia, which are common in skiers, tends to be oblique and spiral and may be also comminuted. Mechanism of injury. The forces are largely angulatory and the resultant fractures tend to be of transverse or short oblique type, often with some comminution, the tibia and fibula being fractured at the same level. Clinical features. Swelling is a prominent feature of combined tibial and fibular fractures, and because the fascial compartment of the leg are relatively close spaces, internal swelling frequently causes one or more compartment syndromes that compromise the circulation to the intracompartmental muscles. Radiographic features. 4 projections, anterior-posterior, lateral and 2 obliques, are sometimes necessary to provide the best indication of the extent of the injury and the relationship of the fracture fragments to one another. Treatment. When both the tibia and fibula are fractured, treatment is aimed at reduction of the tibia. Stable transverse oblique and spiral fractures of the shaft of the tibia can usually be well managed by close means using the principle of the intact periosteal hinge. Figure 17.80. Pillow splint for a fractured leg or ankle. There is less risk of circulatory disturbance and skin maceration with this type of splint than with an air splint. Figure 17.81. Oblique fracture of the midshaft of the tibia and a comminuted fracture of the fibula at the higher level and the result of a rotational injury. A and B. Initial radiograph. Note the overriding of the tibial fragments. C and D. 4 months after close reduction and immobilization of the lower limb in a long leg cast, both fractures are united in satisfactory position. Figure 17.82. Comminuted fractures of the shaft of the tibia and fibula of a 22-year-old man who had been struck by an automobile while on his motorcycle. Left, the initial radiograph reveals shortening but satisfactory alignment. Right, the radiograph 6 months after close treatment and early weight bearing in a long leg cast reveals firm union of the fractures with residual shortening of 2 cm. This amount of shortening is acceptable. Figure 17.83. A and B. Initial radiograph and radiograph 6 months after a comminuted fracture of the midshaft of the tibia and the fibula. Note the large butterfly fragment. The tibial fracture has been treated by open reduction and internal fixation using a plate and screws. The result is satisfactory but could have been achieved equally well by a locked intermedullary nail. For many fractures of the shaft of the tibia, an acceptable alternative method of treatment is functional fracture bracing after an initial period of 3 to 4 weeks of cast immobilization, including the knee joint temporarily. Complications. Fractures of the shaft of both the tibia and fibula are frequently complicated. The most serious complication is osteomyelitis after an open fracture or open reduction of a closed fracture. Fractures of the fibula alone are relatively rare, and you should always look for an associated fracture in the tibia or a fracture dislocation at the ankle with disruption of the tibio-fibular joint. Figure 17.87. Non-union of an oblique fracture in the distal third of the right tibia. Note the broadening and the sclerosis of the fracture ends, the various deformity at the fracture site, and the healed fracture of the fibula. Did you also notice the non-union of the medial malleolus? Fracture of femoral shaft. The femur is the largest bone in the body, and each shaft is particularly strong in adults. There is often extensive tearing of the periosteum and some degree of comminution with resultant instability of the fracture. Massive internal hemorrhage may lead to profound shock. Clinical features. The patient side is grossly swollen from internal hemorrhage. The diagnosis is so obvious clinically, but radiographic examination is best deferred until splinting of the fracture and resuscitative measures have been carried out. Figure 17.102. Spiral comminuted fracture of the distal third of the femur in a 45-year-old woman. Left, initial radiograph revealing displacement and comminution. Center, the position of the fragment obtained by continuous skeletal traction. Right, 3 months after injury. Union is progressing satisfactorily. Complications. The most troublesome late complication is persistent knee stiffness, which is to a large extent preventable through early and continued active exercises. Either the quadricep muscle or the patella may become adherent to the distal end of the femur, requiring surgical release followed by CPM. Intertrochanteric fractures of the femur. Intertrochanteric fractures are especially common in adults older than age 60 and occur more frequently in women than men. They also occur for the same reason, that is, through bone that has become markedly weakened by a combination of senile and postmenopausal osteoporosis. Clinical features. The limb usually appears short and the upper part of the thigh is swollen as a result of extracapsular bleeding into the soft tissues. Ecchymosis may appear in a few days. With intracapsular fractures of the femoral neck, the bleeding is into the joint rather than into the groin or thigh. Radiographic examination clearly depicts the extent of the fracture. Treatment. In recent years, an alternative method of treatment for intertrochanteric fracture is the insertion, under radiographic control, of severed curved Anders nail from the medial side of the distal end of the femur. The nails are driven proximally to cross the fracture site. Figure 17.106. An unstable comminuted intertrochanteric fracture of the left femur of a 74-year-old lady who had fallen and landed on the outer aspect of her left hip. A. In the anteroposterior radiograph, note the comminution and shortening. B. The postoperative radiograph revealed an excellent reduction of the fracture and internal fixation with a compression screw plate, dynamic hip screw or DHS. Complications. Extracapsular or intratrochanteric fractures of the femur have relatively few complications in comparison with intracapsular fracture of the neck of the femur. Non-union and avascular necrosis almost never complicate intertrochanteric fractures. Malunion is the form of coxa is not common, but the resultant shortening seldom exceeds 2 cm. In the elderly, the mortality rate from intratrochanteric fractures of the femur is high, 20% or higher. Fractures of pelvis. Adult pelvis, the most common being serious automobile accidents, accounting for 2/3 of all pelvic fractures, falls from great heights, cave-ins, and crashes. The most important aspects of fractures of the pelvis are not the fractures themselves, but rather the associated complications, extensive internal hemorrhage from torn fascias, and extravasation of urine from rupture of the bladder or urethra. Clinical features. Physical examination reveals local swelling and tenderness. In unstable fractures, there may also be deformity of the hips as well as instability of the pelvic ring. Radiographic features. Special radiographic projections are required to assess the precise nature of the pelvic fracture. The anteroposterior projection provides only a two-dimensional concept of the injury, and the lateral projection, which would normally provide the third dimension, is unsatisfactory because of the overlap of the two innominate bones. Treatment of pelvic fractures. Because the bone of the pelvis is principally of the cancellous type and its butt spine is abundant, fractures of the pelvis unite rapidly. Treatment of the various types of fractures is aimed at correcting significant fracture deformity to prevent malunion and resultant disturbance of function. Types of fractures. Stable fractures of the pelvis. Isolated fractures that do not transgress the pelvic ring, do not interfere with stability of the pelvis in relation to weight bearing, and do not require reduction. Unstable fractures of the pelvis. Fractures that transgress and therefore disrupt the pelvic ring are serious injuries that interfere with stability of the pelvis and are potentially lethal. Figure 17.120 cystogram of a 40-year-old woman who had sustained relatively undisplaced fracture of both pubic rami on both sides. The bladder, which was full at the time of injury, has ruptured through the dome as indicated by the dye that has extravasated into the peritoneal cavity. This type of rupture of the bladder is not due to a tear in the bladder wall from a sharp fracture fragment, but is caused by a compressive blow on a full bladder, the same blow that fractured the pelvis. Figure 17.121 Anteroposterior compression type of unstable fracture of the pelvis in a 30-year-old auto mechanic who was pinned to the wall by a rolling automobile. Note the separation of two innominate bones at the symphysis pubis. The innominate bones have swung outward through the sacroiliac joints, but this is not apparent radiographically. Figure 17.122 Lateral compression type of unstable fracture of the pelvis in a 21-year-old racing car driver whose car was sideswiped by another as he spun out on a tight corner. Note the displayed fractures of the left inferior and superior rami and the disruption in the region of the sacroiliac joint on the same side, the site of the second break in the pelvic ring. The lower end of the mobile segment has been driven medially. Terminology of athletic injuries. Baseball or cricket finger, a fusion of the extensor tendon on the distal interphalangeal joint. Local arms disease, either post-traumatic superosseal bone formation or myositis ossificans on the lateral aspect of the arm. Bone bruise, a superosseal hematoma, usually over the subcutaneous portion of either the tibia or the ulna. Boxer's fracture, fracture of the neck of the fifth metacarpal. Charley horse, a contusion and tearing of muscle fibers with resultant hematoma. Hip pointer, a contusion over the bony prominence of the iliac crest. Jammed neck, a sprain of the joints of the cervical spine, usually from a lateral flexion injury. Jumper's knee, patellar tendinosis. The athlete's response to injury. It is not surprising that although athletes are perfectly willing to risk injury during every competition, their physiological reaction to injury may seem to be unduly marked. It is hardly different, however, from the psychological reaction of a concert pianist or a surgeon who has injured his or her hand, or an opera singer who has injured his or her vocal cords. Aims of treatment of athletic injuries. 1. To base treatment on an accurate diagnosis of the precise nature and extent of the injury. 2. To initiate treatment immediately, at least within minutes of the injury. 3. To provide optimum definitive treatment that will restore function as completely as possible. 4. To accelerate the pace of tissue regeneration and repair. 5. To maintain and improve the function of surrounding muscles. The care of the elderly and their fractures. In this elderly age group, musculoskeletal injuries, particularly if treated by prolonged bed rest, may initiate a cascade of pathological processes that lead to patients' progressive deterioration, even to death. The response of the elderly to injury. For all of these reasons, the elderly person who has sustained a fracture needs and deserves alert medical care, realistic fracture treatment, and kindly consideration. It is important to minimize both mortality and morbidity, both physical and mental. Aims of treatment for the elderly: to relieve pain, to obtain and maintain satisfactory position of the fracture fragments, to allow and if necessary encourage union, to restore optimum function. The treatment of fractures in the elderly. The treatment of specific fractures, dislocations, and joint injuries is discussed in an earlier section of this chapter and need not to be reiterated. Much clinical judgment, both medical and surgical, is required in determining the optimum form of treatment for a given elderly patient. The prevention of fractures in the elderly. One approach to prevention of the increasing problem of fractures in the elderly is the prevention of the predisposing osteoporosis. In the present era of scientific achievement, exemplified by man's conquest of space, the moon and beyond, the prevention of osteoporosis in the elderly through scientific investigation would seem a realistic goal. Thank you.